This is Into the Hen House, a podcast for moms with littles. In this space, we share the stories, experiences, and wild wisdom of mothers. We remember and celebrate the sacred. We are your hosts, Andrea and
Caitlin.
Get ready for some inspiration because it's time to jump into the hen house.
Hello, everyone, and welcome back to the Into the Hen House podcast. We are so excited to have you listening today as we interview kinesiologist Brittany DeMarcke. I'm just going to jump right in here, Brittany. What is a kinesiologist?
So if we go to like the definition I was given in university, it's the study of how the body moves.
Okay.
Just globally, it's a lot of people are kinesiologists and people do a lot of different things within that, but just very basically the study of how the body moves.
Okay. And now you have extra training, special training in myofunctional therapy.
Mm-hmm.
What does that mean?
So full title, orofacial myofunctional therapy. When we talk about orofacial, we're talking about conditions of the face and mouth. Okay. So what I do is assess and treat or correct issues related to clenching and grinding of the teeth, snoring, sleep apnea. We assess for and support with oral ties, so lips and tongue ties. We often will see children with behavioral issues as it relates to sleep. So we see like a couple of other like weird things that people wouldn't think of as mouth problems, but they are. But yeah, that's just it in general, I guess.
Okay.
Awesome. So kind of diving for a little bit here into ties, which actually I have a lot of curiosity about. So there is a lot of pressure for new parents about tongue ties. Mm-hmm. And I feel like a lot of people are told their kids have tongue ties, and there's a lot of pressure to kind of get them taken care of. And then people talk like lip ties, tongue ties. Can you kind of talk a little bit about like differentiating between that and kind of what actually is this?
Okay, so when we talk about an oral tie or a tethered oral tissue, what we're talking about is the fascia. So if you imagine your body is covered, you've got like your muscles and bones and joints, and your body is covered by this layer of saran wrap. Underneath the tongue is an area where you know where that frenulum is, that stringy thing that people, when they lift their tongue up. So that is a band of fascia. And when we talk about having ties, we talk about them being tight, or there's a lot of tension underneath the tongue. So that inhibits the way the tongue is supposed to move naturally. It allows, or it prevents people from putting their tongue up in the roof of their mouth the way they should for proper oral rest posture. But it also changes the way people swallow, changes the way people breathe, and the way their face develops if there's a lot of tension. Just so that people know where I'm coming from. I am not of the belief that if you identify an oral tie, it needs to be released. However, I do believe that there are cases where it's really beneficial to have it released. So I sort of sit in the middle of the road, but we take a really individual approach at our clinic. And there's a lot of other factors that we make sure that we're checking out before that point. So I completely understand what you're saying when you talk about the pressure, because I think over the last 5 years, the knowledge of oral ties has really increased. And anytime we like introduce a new problem, everyone needs to fix it right away, right? So we went through this like super crazy polarizing period where everyone identified ties, all these people were aware of them, and we have to snip them. And then as those things happen and as we get the results of those procedures, we see, oh, maybe this wasn't the best care plan for this person. And we learn that there's other factors that influence tension under the tongue or tension underneath the lip. So I'm finding now people are experiencing a little bit of a whiplash where a lot of people are reluctant to even consider a release for ties. And practitioners are recommending the ties less and looking at the other options that there are for oral tie management.
Okay. So before we jump into what some of those other options are, we've talked about what the tongue tie is, but that's not the only oral tie, correct?
Yes. So there's two other types of ties. So the upper lip tie, and it's basically the frenulum tissue that is underneath the upper lip. Some children will have it quite taut where they can't even open their upper lip. This is the one, if you've got a more old school general practitioner that you take your kids to, you will often hear them tell parents if they are tied there that they'll just fall, bump their lip, and rip it. It's like super old school and actually terrifying advice, because the body heals back. And if it heals inappropriately, then now you're getting a pull in a different direction. So there is your lingual frenulum, so the one underneath the tongue, your labial frenulum up here. Some people will have them on the bottom, but they don't really impact a ton. And then buccal frenum. So that's inside the lip. Children with dimples will often have those buccal frenum. Some people call it frenulum, some people call it frenum. And I find when I say buccal, it sounds better to say frenum than frenulum. I don't know. It means the same thing and they're interchangeable. But so the buccal ties are in the cheeks. And so children that you see the dimple often have that tension because the fascia connects from the upper arch into the cheek.
Well, I've already learned something new today.
Yeah, me too.
I didn't know there were more.
I did not know about the buccal ones.
So you can have them uppers and lowers as well.
Okay.
Yeah.
Okay. So there's a lot of possibilities for things that could be going on inside the mouth.
Yeah, absolutely. I mean, the way the fascia attaches in each person is crazy. It happens in the womb already where we're developing that. So when we're in the womb, before 15 weeks, our tongues are actually glued to the floor of our mouth. They don't differentiate into tongue tissue until a little bit later on in the gestational period. And so that tissue, if all goes well, through a process called apoptosis, it like dissolves away. And in cases where people have more tension, what they theorize is that tissue doesn't dissolve away fully. And so same things with the buccal ties and the lip tie.
Interesting.
That's really interesting.
Mm-hmm.
So would you say then that there are variations in severity? I'm going to link this to what you're just saying, that in this process of apoptosis, how much dissolves away could be different person to person.
Yeah, absolutely. They're coming up with a lot of theories about why or why not this might happen related to like nutrients and genetics. But basically, we have two different types when we're talking about the lingual frenulum, so underneath the tongue. You've seen the babies that are tied all the way to the tip, right? Like that fascia extends physically right to the tip. And we call that an anterior tie, so front of the tongue.
Okay. When they stick their tongue out and it looks like a heart shape, or they can't even stick their tongue out all the way.
So you can see a heart shape in both posterior and anterior ties. But yeah, those babies that are like, they can't stick their tongue out at all. And when you look, they lift the tongue up, if they can even lift it up past the lower gums, where you can see it's like that tissue comes out right to the tip.
Okay.
So that would be a really severe restriction. There's very few ties that would be like, you really should get it tied or really should get it released. That would be one of those cases where feeding would be heavily impacted. There's very few kids that I know that have that type of oral tie that have not been impacted in their feeding journeys.
Okay.
We compensate really well, but that's a tough one. And there's posterior ties where the frenulum tissue, that like line isn't so obvious. It's not attached farther forward on the surface of the tongue. It's attached a little bit farther backwards. Those ones are the ones that are missed oftentimes. Usually those kids can stick their tongue out. The anterior portion of their tongue actually moves around really well because it compensates for not being able to elevate in the back because that restriction is farther back. That kind of answer the question? I know it's
I feel like I'm learning so much. This is actually
I know. It's like we're just a few minutes in and I'm like, I did not know this. So you had kind of mentioned that there, especially maybe like in the last few years, so it's starting to change, there's been maybe a lot of pressure to have any and all ties released. So for the ones, let's say, that aren't super severe and maybe baby can still latch, there still is, but there's ties, what would be kind of the alternatives, other options that people could explore?
Yeah, so it definitely, if we're going to talk about babies specifically, because it changes, the recommendations change once we get a little bit older. But if we're talking about
Oh,
babies,
interesting. Let's talk both, but
we'll talk
babies
about,
first.
okay, let's do babies
Okay.
first. Okay, so babies first. This one, if you suspect a tie, getting in touch with a lactation consultant first and having them assess the tie is huge. People will often get advice from their pediatrician, and their peds aren't actually trained in oral ties, and they don't understand. Um, Sorry, it's Sunday. They don't understand. What's the word I'm looking for? They don't understand the mechanics of milk flowing from breast to mouth or from bottle to mouth. And so when they look at the impact, they're like, well, babies, like wetting diapers and whatever. But the transfer of milk, that's what I was looking for. The transfer of milk isn't efficient. They're going to not understand the fact that maybe baby is not transferring milk efficiently. And so everything looks perfect in the first, 6 to 8 weeks. But over time, the amount of effort required to drink the milk, to draw it out of the breast or draw it out of the bottle, is going to burn into their calorie needs later on. And this is when kids tend to fall off the growth chart, because later on, like that, the calorie output is more than the calorie input. So it's a long way of saying make sure that you have a lactation consultant on board.
Yeah, well,
If
because that
you're
can
issues.
get complicated too, right? Because like when you cut ties when they're very small, it doesn't tend to affect feeding. However, I was told by a lactation consultant that to cut ties later, you just don't want to do unless you have to, because usually that will stop your breastfeeding journey or impact it.
It's a really tricky, timing is really important here. So getting help on board right away. So what a good lactation consultant will tell you and recognize is that tension underneath the tongue isn't always a structural tension, like structural fascial thing. Sometimes when we have an issue like torticollis, which is something you guys would be familiar with, or a head turn preference, which usually goes along with that torticollis, something where the neck and head is turned and things are twisted, you've got a core imbalance. So babe can't actually stabilize it all through the core, which I know is hard as a baby, but babies that have torsions through their lower body, or issues with the hips, so babies who were breech and then their hips are wonky, the condition of the body and the way the rest of the body moves will impact the way the tongue moves as well. So you could have a baby who doesn't necessarily have that structural restriction, but the way the rest of their body functions impacts the way their tongue moves.
Right.
So it's important to have your lactation consultant on board, because they want to make sure throughout this whole process that they're checking milk transfer, the way the tongue moves, but you also want body workers on board with babies. So the difference, like just quickly, the difference between older kids and babies is babies, everything has to be done passively, right? Like you can't tell them to do exercises to learn how to move their tongue. So getting body workers on board, cranial sacral therapy is incredible because it works on that fascial system. Osteopathy is good too. That's, where cranial sacral therapy came from. So if you got a good osteopath, just making sure that everything is aligned so that baby's not trying to feed like this and we're calling it a tongue tie because things aren't working. You snip it and then this doesn't change. Right? So supportive therapy before and after with body work is really important, and a good lactation consultant will recommend that.
Okay, this makes sense. I know for us, from a chiropractic perspective, even like misalignment, stress, pressure, interference from that upper cervical because it's so close to the vagus nerve and the glossopharyngeal hypoglossal nerve, that pressure can actually then impact the nerve, which then impacts the tongue's ability to move. So you could do all the snips in the world, but if that nerve is not able to tell the tongue how to move properly.
Yeah, exactly. So that is a huge, huge thing that people are missing. Is like, especially in those early days, a lot of ties will be like identified in the hospital, and then parents rush to get them done right away because the pediatrician or their nurse suggested it. And it's really damaging because you didn't check out anything else. The other thing that's really important that parents don't realize is, so they go and maybe they did all the body work and then they got the release. They did all that portion. Your tongue starts practicing the swallow at 15 weeks. And so if you think of how many repetitions of that improper tongue patterning, that improper swallowing pattern that the baby goes through rep after rep after rep as they practice with the amniotic fluid, and then they come out and they still have that pattern, and we, snip the tongue, we release it, and that pattern is expected to just magically change because it has more range of motion. So what we're telling parents often, and our clinic is actually working on a way to get this out to parents, an oral play guide where you actually have to go in pre-release and post, and you help baby reorganize that tongue pattern. So we just simply talk about encouraging tongue lateralization. Before that 4-month mark, 3-4 months, we're talking about tongue cupping. So you can actually train the tongue to cup the way it's supposed to, the way it wouldn't necessarily do if it was tied. Tongue elevation is important. So working on getting the tongue up into the palate, because that's ideally where we want it to be. But if we don't train that, again, if we don't fix those compensations, that pattern's going to show up, and you're going to end up with kids who, even though they got a tongue tie release and you did all the body work and you did all the right stuff, they end up with an open bite because their tongue is thrusting, and so they've got orthodontics that have to close that bite.
Correct me if I'm wrong. What I think I'm hearing you say is from 15 weeks in utero, the body is building muscle memory, which I think that's an easy term for most to understand.
Yes.
And so now we've got this neurological muscle memory path that baby has developed for another 25, I think I can do math, weeks in utero, plus however long once baby has been born. And the expectation has kind of historically been, once we release it, that we just poof, all that muscle memory is supposed to be gone, and we're supposed to just now know how to swallow properly.
Yeah. And here's a couple stretches. And there are some release providers now saying, oh, well, the stretches don't help anyway, so you don't have to do those, which is, it's because they're like, well, this isn't working, so obviously these recommendations aren't helpful, but we're not replacing them with things that
with anything else.
Yeah.
So we've said chiropractic, osteopathy, craniosacral, pediatric massage, a great kinesiologist who is trained in oral myofascial exercises, a lactation consultant. These would all be great people to have on your team prior to anything else.
Yeah.
And that's not to say that you don't end up choosing that a release is the best option, but these would be all the places maybe to start.
Okay. Yeah.
A long list.
It is a long list, and you don't have to have all of them. I mean, I would obviously recommend a lactation consultant, and then some sort of body worker that you're comfortable with. Some people hear about craniosacral therapy and it's very light touch and it doesn't look like anyone's doing anything, and so they're kind of turned off. And so then if chiro is your thing that you're comfortable with, or osteopathy, like some sort of other body worker that is knowledgeable about cranial development and the tongue and the way it moves, is really important. And then, oral play, which is just something that I think we need to get more access to people to have, because there was so the process of tongue tie release, if you choose to go through it, again, you don't have to, but if you choose to go through it, is traumatic for babies. You've got strangers that are putting their tongue in, or your fingers in their mouth, moving your tongue around. They got to numb things up. Like, it's very invasive. And so if you can do that oral play and actually have your babies exposed to having someone's finger in your mouth, for one, the exercises after will be easier, but the actual process of the release is less traumatic.
I'm going to ask like a really, I feel like this could be a triggering question. I'm not familiar enough with the process itself, but my understanding was that they don't numb when they do the laser cut. Can we get clarity on that? Like,
that has not been my experience.
Okay, so they do numb.
Yeah.
Okay, this like gives me some relief, because my understanding was like, oh my gosh, these poor teeny tiny babies, how are we saying they don't feel this? Like, of course they would feel it.
Yeah. No, they do. I mean, a good provider will numb it up.
Okay.
So they put the like that numbing gel and then a local
Or gel.
Or yeah, it's something like whatever their brand of it is.
Sure.
And then a local. The typically the trauma comes from you having some random person with big glasses and whatever, and kind of being held down while they cut it away. So I can completely understand. I went through the process with my youngest, and it like, after, our dentist was fabulous who did it. They were great. That like very good experience from what they could give me in terms of like comfortability. But I remember like holding my son, and then after it happened, the dentist was talking to me, and I was like, hold on a second, like my blood pressure just dropped. I need a minute, because everything comes down and you're kind of, so it is a traumatic process. And I can completely understand why people have been turned off of it or are hesitant because they hear these stories.
Mm-hmm.
It's fair.
So how extensive is the actual cut? Because some people will say, oh, it's just a little tiny snip. Like, well, just go in there and snip it right here, right now. And then others, like I saw a surgeon who was talking online, talking about how it's actually like, a deeper, longer, more extensive cut. Like,
so it depends.
Allegedly to do properly. And it may depend what the tie is too.
Well, it depends on the tie, the nature of the tie. It also depends on the practitioner. So I don't know where all of your listeners are from in the States. It's very popular for providers to use a laser. So either a CO2 laser or a water laser. In Manitoba, which is where we are, me and Caitlin, most providers, and not all, but most of them use the water laser or the CO2 laser. So it basically just like zaps the tissue away. There is a provider that uses a scalpel. So when we talk about like a snip or a cut, like they use a scalpel to cut it away. That is more popular if you get a release done in the hospital. There is one provider in Winnipeg who does it through multiple incisions, which I'm trying to be careful.
Yeah, don't make anyone wrong. My face is betraying me so hard right now. I'm like trying with everything I have not to go.
Right? Yeah. Not like there's lots of research to suggest that one is better than the other, but I really think it comes down to, like, as a parent, being comfortable with your provider, doing your research. In our clinic, we give everyone like the lay of the land, but we obviously have our favorites because we see the releases and they're really good, or really not, and then we tend not to send people that direction. But the ones that are doing better releases are usually using the laser, because with babies you have a really limited window of opportunity, right? Like there's only so long that they're going to tolerate being essentially held down. With older,
mouth forced open.
well, that's just it. So the laser is a lot quicker, right? And so then you have to consider, like, there's a potential for a little bit more damage or a little bit more what's the word I'm looking for, collateral, right? But yeah.
Okay, I need a second to just recoup myself, because I feel like even hearing about this, like it hurts my soul a little bit. It does. I won't lie. I won't say that like, oh yeah, this just makes it sound like so much easier. No,
it's hard.
It's horribly hard.
Yeah. It's horribly hard. And as a parent who had my youngest had severe, oh my goodness, I clearly still have to work through this, severe reflux. He was puking constantly. We were up all night. He could not sleep. Like, it was absolutely awful. He had a posterior tie. We did all the body work. We did all the follow-up. At 6 weeks post, which is usually when you see like the best results, he was still puking. It had improved, but he was still puking. And this is actually what led me down to getting this training. Was I had to go and do all this other research, and I figure out, oral play is really important, and we have to retrain the tongue and all of these things. So once I had the knowledge in place, we retrained the pattern of his tongue. He now, well, he didn't have reflux. What was it? By 8 weeks, his reflux was gone. He was sleeping better. He sleeps with his mouth closed. He is way less sick than his brother ever, because he can filter and process and all of these things. His emotional regulation is significantly better. I mean, he's still 2.5, so we're like in that terrible phase 2, right? But for us, it was a good decision.
Okay.
But it was still horrifying to go through, because he was a little bit older by the time we realized. He was 4 months by the time we realized that this was it, because my concerns about his reflux were just like brushed off by our ped. So it took a lot to get to the point where we finally got the lactation consultant and the support and the body work, and I did all of the things. And yet the release was still, with the oral play and retraining the tongue, was still the best decision for us. So there are cases where it really sucks, but it's like trying to think of a comparable surgery, because of course now I feel differently about adenoids and tonsils too. You know what I mean? Like, there are Western medicine and surgery still sometimes have their place. And
Yes.
yeah, it's just making sure that we are also supporting everyone else too, and supporting them in the best pre and post care.
Yeah. So may I ask one more question?
Yeah.
So with the ties, if it's, released, what is the process? I know you've mentioned kind of like oral play and things like that, but what is the process afterwards? One, to make sure it doesn't grow back. Can it grow back afterwards? Like reattach?
Yeah. So that tissue heals. Your body is super efficient, and if it had tissue there before, it will heal. The goal of the release is that you take the tissue away, and then when it heals back, it heals lengthened. So with babies, that means making sure that we're stretching the tissue out, and as it regrows, we're helping it reform in like nice clean lines, right? So wound massage, stretching the tongue up. We use a stretch called the forklift, where you put your fingers up and you forklift their tongue and lift it up to the roof of the palate. In terms of oral play, we place tongue or finger on the tongue, and we encourage that elevation of the tongue. When they have more range of motion and they're not limited laterally, we work on lateralization, so tongue back and forth, side to side, making it work more efficiently. And then like closing the mouth to encourage that tongue to reach up into the palate, because naturally as babies, that's where the tongue's going to want to go if it has the ability to do so.
Okay. And I guess like on the flip side of that, what are some things that we might see? I'm going to start with babies, and I guess as they become a little older, what are some things we might see if a tie was severe enough, and maybe not even if it wasn't severe enough, if a tie existed and was not rehabbed in any way, what are some things we might see down the road as a repercussion or a consequence of the tie?
Okay, so we'll bring it back to the beginning. So in a perfect world, the tongue has enough mobility to rest on the palate, so in the upper arch from the front to the back. It doesn't thrust against the teeth. It sits kind of the bumpy spot right behind, helps form the arch. When that happens, the mouth and the lips are closed, and breathing happens through the nose. Okay? So if we imagine that that's like perfect posture, that's what we want. We want babies sleeping with their mouths closed. When things go wrong and you see a restriction, what happens is the tongue cannot stay up in the roof of the palate, and our bodies are really efficient. So then they go, we're going to hang out on the floor. If that happens and the mouth hangs open, you're going to see the narrowing of the jaws. The upper arch narrows. That's when we get kids with like really crowded teeth, because the tongue should have acted like a retainer to help broaden the upper arch and the lower arch, but it's not doing that. So things grow narrow. We get palates that are a little bit higher. Because the palate is the floor of the nose, the palate, or the roof of your mouth sort of impinges, it goes up into the nasal space. So those nasal cavities get narrower. The tube that you're supposed to breathe through will get narrower. This isn't always the case. Some people have really good genetics, but typically this is the pattern that we see. So then the nose gets more occluded or more stuffy because it doesn't have a whole lot of room. That can happen. Later on, we see sometimes kids will have, because they can't control their tongue really well, food tends to be easier to go down the wrong hole, or choking happens. And so that leads to a lot of kids developing what we think is picky eating, but it's actually survival. So their bodies, for example, like don't like really chewy foods like steak or chicken or trying to think, like basically meat, because their bodies have learned, oh, this is really hard to chew. This is really hard to swallow properly. And so I don't like it. And then it becomes, I don't like meat, because their bodies early on learned that's not a safe food to swallow. Right?
The body is so amazing. Like,
it is.
Yes, of course, we can see these things as consequences, right? Like, and they do have negative impact. But also the fact that the body was like, wow, I can't properly chew this because it's uncomfortable. So let me do this adaptation where I'm going to tell your brain that you don't like this, so that you only want to eat mashed potatoes.
So that you're safe.
So you don't choke. Yeah. Like
100%.
That part's a little bit incredible. But
it is.
And I digress. So
it's
we have so far
mechanism.
Palate improper development, crowded teeth, possible breathing occlusions.
Mm-hmm.
I imagine those can also lead to getting sick more often because we're not having proper filtration.
Exactly.
We have choking hazards. We have picky eating.
Yeah.
I imagine there could be more. Speech?
There's one more big one, and this is what we see in the clinic a lot. So we think of sleep apnea as an adult problem, but sleep disordered breathing actually affects a lot of kids. So your hard to settle, never slept through the night kid likely has an airway problem. So we think about nasal breathing versus mouth breathing. Nasal breathing, you talked about some things. So it filters, warms, slows down the air, produces nitric oxide, which helps with the oxygen conversion into the muscles. When that's not happening and we're breathing through the mouth, we actually have a lot. For one, we're not filtering. We're not really warming. The air comes in really fast. But if you think about the nice little tube that your nose is that goes straight to the lungs versus the mouth that has the tongue hanging out, has teeth, there's a lot of resistance that occurs. It doesn't air doesn't smoothly go down. So we get upper airway resistance. We also, when all the tissues are slack because everything is hanging open, we get airway collapse. So the throat actually collapses in. So we think of that as an adult thing. It happens in kids.
Wow.
Because everything gets slack and weak, right? Like it just doesn't work the way it should. So it doesn't hold everything open. Clenching and grinding happen as your body's adaptive way to keep you alive. You clench and you create stability in your jaw and in your airway.
Of course, it's an adaptation.
It's an adaptation. It is. And it's super amazing that our body's like, I'm not going to let you die.
Yeah,
make sure
that is super amazing. So what if you have all this tension in your jaw and your teeth are eroding and you're getting headaches because everything's so tight? You're still alive.
You're still alive. It's so good. We adapt really well, but we can see how it can be problematic. You get teeth that break. Weaker teeth are more prone to cavities. People are putting night guards in, and I won't even get into that because that's another rabbit hole. Maybe we talk about that another time. But all of these things, and so the two things that happen, your oxygen levels drop because, for one, you're not producing nitric oxide, which helps your body convert that oxygen into your tissues. But you're also, because there's so much resistance, you're actually not getting as much oxygen when you breathe through your mouth and when you're occluding. And some people even kids will have apneas where they just stop breathing because everything collapses in. Really scary. Terrifying. Yeah, it is. When that happens and you don't have as much oxygen, you don't sleep as much, but you also don't sleep as well. So then we end up with children who have ADHD-like symptoms, learning and memory problems because they're just not getting quality sleep. Snoring. Go ahead.
Because they're exhausted.
Yeah, because they're not getting good sleep.
Wow.
So snoring is a sign that we are likely breathing through our mouth and we are getting that resistance, right? Like the air isn't going through smoothly. Snoring is a precursor in kids, is a precursor to sleep apnea as adults. And we know from all the studies that they do on adults, sleep apnea increases your risk for heart attack, diabetes, like all sorts of other crazy health problems. So if we think about like, doesn't seem so crazy as kids, but it becomes a big problem later on. And it realistically is, it impacts the kids. All that to say, just because you have an oral tie doesn't mean that a release is the only thing that will prevent these things. So if we bring it back to body work, to work on the fascia and release the fascia, exercises to strengthen the tongue, lips, and the jaw to keep everything stable. If we can do all those things and retrain your tongue to maintain that resting oral posture that we talked about, you don't necessarily need a release. So we can do that. That's
on its own, if you will, like, because we've taken care of, we've helped the system function appropriately to where the tie is not the problem.
Yeah. And so things like weakness, things like coordination, all of those can make a tie look like a tie functionally when realistically it's just the tongue is weak from years of whatever. So people could have chronic nasal congestion from being in a home that's older and it's stuffier. Maybe there's mold, maybe there's just more dust. Maybe they grew up, I've got a client who grew up in a Chinese food restaurant. And so like all of that inflammation from the frying foods and stuff like that, all the smells, he just couldn't breathe through his nose. It was always stuffy. And so his tongue and jaw and lips got weak from just not being used the way they should. So that's not a tie, but everything got weak and uncoordinated. And so now we have to retrain it so that he can sleep better.
Yeah. So as far as speech goes, for people who have trouble speaking or are maybe slower to start speaking or have developed a lisp or different things like that, can that be related as well?
Yeah, absolutely. So I am not a speech pathologist, but I work really closely with a couple who are myofunctional therapy trained as well. Not all SLPs or speech language pathologists have the training, but in the case where children fail out of or like age out of speech and they just have lisp for the rest of their life, chances are there is some sort of orofacial function issue or a tongue issue, whether that's a tongue tie. Oftentimes it is, but that can absolutely impact. If you cannot elevate the back of your tongue, you can't create the R sound properly because the back of your tongue braces into your upper arch to create the R.
Right.
So if you think about that posterior tie where that back of the tongue doesn't lift up, it can't actually lift up and brace to create the R. Right? If your tongue is weak and uncoordinated, think about if you're just say weak and uncoordinated and think about how many different places your tongue touches on the roof of your mouth. Right? So if you've got weakness or coordination issues, you can't do that smoothly. So the tongue function absolutely plays into speech, but not all speech language pathologists look at it that way.
Okay.
Wow. And to those who are watching the video, you can see all of us like, trying to,
Right.
we look funny. It's because we're like, trying to move our tongues. No.
In my mouth, as I say all the things right now. Okay, so that is something we could look out for then. If there's speech issues and someone's looking for a speech language pathologist, looking for one who is trained or has that extra training in oral myofacial therapy would be a benefit.
Absolutely. Yeah.
You're already going to go pay for a service from a provider. Now I'm thinking, let's make sure that we're getting the provider who has the most possible knowledge and expertise so that we can do our best to yield the most positive outcome.
Yeah, absolutely.
Okay. Is this something that you would say, like, it should be easy to garner that information?
I feel like most people who have the training will display it because it's a relatively new therapy, at least in Canada. In the States, it's a little bit more popular. But yeah, they will usually display it somewhere. Some people, there is a board certification, but it's not common to find that. The process is newer and a little bit convoluted, I find. But yeah, it should be displayed somewhere on their social media or website or whatever. You can just ask for orofacial myofunctional therapy training.
Okay. Andrea, we're going to make sure we put that in the show notes so that
Yes.
all of our listeners are like, what's that word she said again?
All right. Thank you so much, Brittany. Thank you for all of this information. This has been so fascinating. And I feel like I've learned so much. And we really appreciate you being here. And we will be sure to put all of your information and some resources into the show notes for our beautiful, wonderful listeners. And to those who are listening, thank you so much for being here. And we are going to have another episode coming up with Brittany talking about mouth issues for older children and adults and going down a few extra special little rabbit holes in that range of things. So definitely be sure to check out her next episode as well. So thank you.
Thank you.
Thanks for having me.
Thank you so much for listening. If you are loving this podcast, please go ahead and subscribe and leave us a review. Both of these really help the show. As you go out into the world this week, know that we are sending you so much love and wishing you a wonderful and beautiful day. And we will see you back here soon.